Hello, imagine a superhero drug that saved millions from malaria. But guess what? The parasite it fought evolved and made it useless. Crazy, right?
That's chloroquine for you. Total glow up then flop.
Yup. Shows even our best meds can fail. Today, we're spilling the tea on chloroquine and mefloquine, how they worked, why they flopped, and what it means for fighting diseases.
We'll keep it simple. No fancy jargon, just the juicy bits. Think of it as your Malaria 101 cheat sheet.
Exactly. So, first off, these drugs are like cousins, both part of the quinoline family. They attack malaria when it's partying in your red blood cells, the stage where you feel super sick.
Chloroquine was the star back in the day. Cheap, easy, worked like a charm. Until it didn't. Parasites mutated, pumping the drug out like it's trash. Efflux pumps, LOL. Survival of the sneakiest.
So how'd it even work? Basically, the parasite eats your blood cells but poisons itself with waste. Chloroquine blocked its cleanup crew, so the garbage piled up. Boom, dead parasite.
But here's the kicker. Chloroquine sticks around in your body for weeks. Great for prevention, but side effects? Nausea, dizzy spells, and, wait for it, it can mess up your eyesight forever if used too long. Yikes.
Then there's mefloquine. Similar vibe, but works more like a DNA blocker. Also, parasites outsmarted it. Now, doctors have to play detective, use drug combos and track where the malaria's from to pick the right meds.
Oh, and plot twist. Chloroquine's now used for lupus and arthritis. One drug, multiple gigs. But during COVID, total flop. Don't argue with me.
Bottom line, fighting diseases is like a video game. Parasites level up, we need new weapons. Stay smart, use meds right, or we're all back to square one.
Mic drop.
Like what?
Mood changes, confusion, psychosis in some cases. Also, hemolytic anemia in people with G6PD deficiency, that's a genetic condition. Muscle weakness, hearing issues, low blood sugar, methemoglobinemia.
Methemoglobinemia.
Methemoglobinemia affects how blood carries oxygen, and crucially, overdose is extremely dangerous, potentially fatal very quickly.
That's a serious list. So who absolutely shouldn't take it?
Well, definitely anyone allergic to it, anyone with existing retinal problems, people with psoriasis or porphyria usually avoid it too.
And caution in other cases.
Yeah, exercise caution with liver or kidney or heart disease, epilepsy, G6PD deficiency as mentioned, and you have to be careful if someone's taking other drugs that affect heart rhythm. Pregnancy and breastfeeding also need careful risk-benefit discussion.
Okay, let's switch gears to mefloquine. This one came along specifically because chloroquine stopped working, right?
Exactly. Mefloquine was developed in the 1970s, a big collaborative effort involving the U.S. Army, WHO, Hoffman-La Roche, precisely to tackle chloroquine resistance.
So it was the next line of defense?
It was. Approved in the U.S. in '89. It was a big step forward against resistant malaria, but it quickly gained a reputation, maybe notoriety, for its own side effect profile, especially neuropsychiatric ones.
Right, I've heard about that.
But it's still a valuable drug in certain specific resistant situations today.
So how does mefloquine work? Different from chloroquine?
Yes, different mechanism. It's also a blood schizontocide, kills the parasite in the red blood cell stage. But its main target is protein synthesis.
Making proteins.
Right? It binds to the parasite's ribosome, the protein building factory, specifically the ADS ribosome, and basically shuts down production of essential proteins.
So it stops the parasite building what it needs to survive.
Precisely. There were earlier ideas about it affecting pH or binding heme, like chloroquine, but ribosomal inhibition is now seen as the key mechanism.
And how does the body process mefloquine? Similar long half-life?
It does have a long half-life, yes. 2 to 4 weeks. It's well absorbed orally, even better with food. Reaches peak levels in maybe 6 to 24 hours.
Okay.
Spreads widely in tissues, binds very tightly to plasma proteins, like over 98%. It also gets concentrated in infected red cells, which is good.
Targeted delivery?
Kind of. It's heavily metabolized in the liver, mainly by that enzyme CYP3A4, into an inactive form. And unlike chloroquine, it's mostly eliminated via bile and feces, not so much urine.
Clinically, when is mefloquine used now?
For treating mild to moderate P. falciparum malaria, including chloroquine-resistant strains, and also P. vivax. And it's used for prevention, prophylaxis in areas where those are common.
How is it typically given?
Treatment is usually a single oral dose, maybe split sometimes. Prevention is a weekly dose. You start before travel, take it during, and continue for about 4 weeks after leaving the malaria zone.
What are the key things someone taking mefloquine needs to know?
Yeah, again, correct weight-based dosing, especially for kids. Take it with food, helps absorption, less stomach upset. And for prevention, it's often advised to start it a few weeks before you travel.
Why is that?
To see if you tolerate it okay. Because of those potential neuropsychiatric side effects, you want to know if it's going to cause problems before you're actually traveling.
Makes sense. And if you vomit after taking a treatment dose?
Yeah, if that happens soon after taking it, you might need to take another dose. There's specific guidance on that.
Okay, let's tackle the side effects. This seems to be the big talking point with mefloquine.
It is, and it's a valid concern. Common side effects are kind of standard nausea, diarrhea, dizziness, headache, sleep issues like insomnia, or really vivid dreams, maybe rashes, muscle pain, fever, chills.
But the serious ones?
Are primarily neuropsychiatric. This is the big one. Anxiety, depression, paranoia, hallucinations, confusion, agitation, really unusual behavior, and rarely but importantly, suicidal thoughts or actions.
Wow, that sounds quite severe. And can they last?
Yes, that's a key point. These effects can sometimes be long-lasting, even potentially permanent after stopping the drug in some people.
That's scary. Any other serious ones?
Neurological issues too. Dizziness, vertigo, tinnitus, losing balance, even seizures. Cardiac effects like QT prolongation can happen. Caution with liver problems. And very rare blood disorders have been reported.
So given all that, who absolutely should not take mefloquine?
Right, the contraindications. For prevention, it's generally a no-go if you have an active or recent history of depression, anxiety disorders, psychosis, schizophrenia, or seizures. Or, of course, if you're allergic.
And caution in other groups?
Yes, caution with liver or heart disease. With epilepsy, it should really only be used for treatment if there's no other good option. And again, pregnancy and breastfeeding require that careful risk-benefit assessment.
What about drug interactions? Anything major to watch out for?
Oh yes, quite a few. Severe interaction with one drug, lumefantrine. Serious interactions with, well, over 140 others according to some databases.
That's a lot.
It is. It's contraindicated with another antimalarial, halofantrine, risk of heart rhythm problems. Also with strong inhibitors of that CYP3A4 liver enzyme because they can boost mefloquine levels and risks.
So need to be careful with other meds.
Definitely. Caution with other QT prolonging drugs. Risk of seizures might go up if used with quinine or chloroquine, can make some anti-seizure meds less effective. And maybe the oral typhoid vaccine too. And other drugs affecting CYP3A4 can either increase mefloquine levels and risk or decrease its levels and effectiveness.
And has the Parasite started fighting back against mefloquine too? Is there resistance?
Unfortunately, yes. Resistance has emerged, especially again in Southeast Asia, areas like the borders of Thailand, Myanmar, Cambodia, parts of Vietnam. That's a hotspot for multi-drug resistance.
How does that resistance work?
Seems to be mainly through those efflux pumps again, particularly one called PFMDR1. It just pumps the mefloquine out of the parasite.
The same trick.
Often, yes. And there's evidence of cross-resistance. Parasites resistant to mefloquine might also be resistant to chloroquine or quinine. It really hammers home why we need to use these drugs carefully and keep monitoring resistance.
So, if we compare chloroquine and mefloquine side by side, what are the biggest contrasts?
Well, the core mechanism is different, right? Heme detoxification for chloroquine, protein synthesis for mefloquine. Chloroquine hit more malaria species initially and had those autoimmune uses. Mefedrine works against many chloroquine-resistant Falciparum strains.
And the side effects?
That's a major difference. Mefloquine has that much higher risk of serious neuropsychiatric issues. Chloroquine, especially long-term, carries that significant risk of irreversible eye damage, the retinopathy. Their interactions, contraindications, resistance patterns. They all differ quite a bit.
It's really striking how both of these, important drugs have faced such big hurdles with resistance and side effects.
It really is. And that brings us to thinking about toxicity more broadly, especially with chloroquine and its cousin hydroxychloroquine when they're used outside of malaria.
Right. Hydroxychloroquine. That's the one used more often now for things like lupus and rheumatoid arthritis. Generally less toxic.
Generally considered less toxic, yes. And it's become a mainstay for managing several rheumatic diseases.
How does it actually work in those autoimmune conditions? It's still kind of amazing that an antimalarial drug helps control the immune system.
It is fascinating. It's thought to have anti-inflammatory and immunosuppressant effects. It modulates the immune response in various ways. We think it might interfere with processes inside immune cells, maybe related to those lysosomotropic effects we talked about.
Affecting the lysosomes again.
Potentially, yes. Interfering with antigen presentation or cytokine release, perhaps. It acts as a steroid-sparing agent, which is a huge plus.
Meaning patients can take less steroid medication.
Exactly. Which avoids a lot of the nasty long-term side effects of steroids. Hydroxychloroquine itself is usually well absorbed, reasonably well tolerated at the doses used for autoimmune disease, though that retinopathy risk is still there with long-term use. And interestingly, it's often considered relatively safe in pregnancy and breastfeeding in this context.
Let's go back to that retinal toxicity for a moment. What exactly is happening in the eye?
Okay, so both chloroquine and hydroxychloroquine really like melanin, the pigment in the eye. They bind to it, especially in the retinal pigment epithelium, the RPE layer.
Which is important for vision.
Crucial. Supports the photoreceptor cells. The drug builds up there, particularly in the macula, the central vision area. It seems to damage the cones, the cells for color and detail, mainly in a ring around the very center, the parafoveal region.
How does it damage them?
It might directly poison them, or it might mess up the RPE's housekeeping job by inhibiting those lysosomes, disrupting how they clear out waste from the photoreceptors. Over time, the RPE cells can die or move, and the photoreceptors are lost, and that vision loss is irreversible.
And distinct from the corneal deposits?
Yes, the corneal deposits, vortex keratopathy, that's different. That's the drug binding to lipids in the cornea. Looks like little whorls, usually doesn't affect vision much, and clears up if you stop the drug. The retinal damage is the big worry.
And you mentioned increased cardiac risks during the COVID-19 situation with hydroxychloroquine use.
Yes. When it was being tried off-label, often at higher doses, there were more reports of cardiac issues. Things like QT prolongation, which increases the risk of dangerous arrhythmias like torsades de pointes, even cardiac arrest. It was likely a mix of dose, maybe underlying illness, and interactions with other drugs patients were getting. Ocular toxicity wasn't such a focus then because the treatment courses were much shorter.
So how do doctors keep tabs on this potential eye damage in patients taking these drugs long-term for autoimmune conditions? What does the screening involve?
Screening is absolutely vital. It starts with a baseline eye exam when the drug is initiated, then regular follow-ups. These include automated visual field tests, checking peripheral and central vision for subtle blind spots, and advanced imaging. SDOCT, that's optical coherence tomography, gives incredibly detailed cross-section pictures of the retina. Can show early thinning or structural changes.
Like the flying saucer sign?
Exactly. That's a classic description of an SDOCT finding in early toxicity. Fundus autofluorescence, or FF, looks at the health of the RPE layer. And multifocal ERG tests the electrical function of different parts of the retina.
How often do people need these tests?
Depends on their risk factors. Duration of use, daily dose relative to weight, age, kidney function. These all play a role. People at higher risk need screening more often, maybe yearly after 5 years of use. Asian patients might need slightly different visual field tests, like a 10-2 pattern, as they can sometimes get a different pattern of damage.
And what about an acute overdose? Someone takes way too much chloroquine or hydroxychloroquine at once. What are the immediate dangers?
Acute overdose is a true medical emergency. The biggest immediate danger is the heart. High drug levels hit the cardiac conduction system hard, blocking sodium and potassium channels.
Leading to?
Severe EKG changes, widened QRS, prolonged QT, dangerous arrhythmias, low blood pressure, circulatory collapse. It can happen very fast. Plus, you can get seizures, coma.
So quick action is needed. What's the evaluation?
Get a history. How much? When? Check labs. Electrolytes are key, especially potassium. It often drops dangerously low, hypokalemia, glucose, kidney, liver function. Drug levels can confirm, but aren't always immediately available. Continuous EKG monitoring is absolutely essential.
And the management in the hospital?
It's aggressive supportive care. IV fluids, oxygen, maybe pressors like epinephrine to support blood pressure, possibly activated charcoal early on if they can take it safely. Often need intubation to protect the airway.
Any specific antidotes or treatments?
There's no direct antidote, unfortunately. High-dose diazepam, a sedative, has actually shown some benefit in reducing mortality in studies, which is interesting. Sodium bicarbonate isn't usually recommended like in some other overdoses because of the potassium and QT issues. It's really about intensive support and managing complications.
It sounds like you need to be sure it is chloroquine/hydroxychloroquine toxicity and not something else that looks similar.
Definitely. The corneal whorls could be from amiodarone or Fabry disease. The retinopathy needs distinguishing from macular degeneration or inherited retinal diseases. And the acute overdose symptoms can mimic overdoses of beta blockers, calcium channel blockers, loperamide, clonidine, even quinine poisoning, which also causes cardiac issues and low blood sugar.
What's the outlook, the prognosis for these toxicities?
For the chronic eye damage, sadly, the vision loss can keep progressing even after stopping the drug. It's often permanent. The corneal changes usually resolve. For acute overdose, it's very serious. Mortality rates are quoted around 10 to 30%. Even small amounts can kill a child. A couple of times the therapeutic dose can be fatal quickly in adults. It's a very dangerous overdose.
And potential long-term complications?
For chronic use, obviously, permanent vision loss despite screening. For acute overdose survivors, there can be lasting neurological or cardiac damage. Multi-organ failure is a risk during the acute phase.
Who should be consulted in these cases?
For any overdose, call poison control or a medical toxicologist immediately. For the chronic eye monitoring, it has to be an ophthalmologist experienced in detecting drug-induced retinopathy.
Okay, let's circle back to the autoimmune uses. You mentioned the steroid-sparing effect being a big deal.
Huge deal. Allowing patients to reduce or avoid long-term steroids is a major goal in managing conditions like lupus or RA. Hydroxychloroquine helps achieve that for many people. And as we said, it's generally pretty well tolerated at those doses, easier than chloroquine. Relative safety in pregnancy breastfeeding is another plus.
Are there specific drug interactions to worry about in the autoimmune setting?
Mostly manageable, there can be a good interaction with methotrexate in RA, might increase levels of some anti-inflammatories like indomethacin, might decrease digoxin levels. And yeah, that interesting finding that smoking might make it less effective for skin lupus.
What are the typical doses and how long does it take to work?
Usually lower doses than for malaria. Hydroxychloroquine often starts around 400 milligrams daily, then drops for maintenance. Chloroquine might start a bit higher. But these aren't quick fixes for autoimmune disease. It takes weeks, often months, to see the full benefit.
So patience is required.
Definitely. Higher starting doses might speed things up slightly but mean more stomach upset. The aim is the lowest effective dose long-term. Checking blood levels isn't generally helpful. Sometimes it's combined with other drugs like quinacrine for tough skin lupus to boost effects.
And it sounds like for lupus, SLE, it's really a fundamental treatment.
Absolutely. A cornerstone for over 50 years. It reduces disease activity, cuts down flares, helps prevent long-term organ damage. Plus, the steroid-sparing potentially good effects on lipids, maybe bone protection, and that anti-clotting effect.
Anti-clotting.
Yeah, it seems to inhibit platelet aggregation. Studies suggest it lowers thrombosis risk in lupus patients, especially those with antiphospholipid antibodies. Really valuable for mild to moderate lupus, especially skin and joints. Helps with fatigue, General symptoms too, though evidence on fatigue is mixed.
How does it stack up in rheumatoid arthritis?
Reasonably effective. Maybe 70% get some improvement with hydroxychloroquine, perhaps not as strong as methotrexate when used alone, but works well in combination therapy. Starting it early might lead to better long-term outcomes, seems less potent for RA joints compared to its effect in lupus generally.
What about Sjögren syndrome? The dryness.
A bit of conflicting data there. It might help with joint and muscle aches, sometimes seen in Sjögren's, but doesn't seem to do much for the dry eyes and mouth, which are the main symptoms. It has immune effects, but its role isn't fully clear. More research needed.
And briefly, any other autoimmune conditions where it's tried?
Yeah, quite a few, often based on less strong evidence. Dermatomyositis, especially skin stuff, often with steroids. Sarcoidosis, maybe skin lesions. Psoriatic arthritis is controversial. Some say it helps, some say it worsens skin. Palindromic rheumatism, maybe reducing episode frequency. Some reports in rare things like RS3PE syndrome or erosive osteoarthritis, but often it's uncontrolled studies or case reports for these less common uses.
And the side effects in this context? Mainly dose-related.
Generally, yes. Tolerability is better with hydroxychloroquine than chloroquine at these doses. GI upset is common but often passes. General stuff like headache, skin issues, rashes, pigment changes, itching are fairly frequent. And the eye's retinopathy is the main serious concern long-term, hence the monitoring. Corneal deposits are common but reversible. Other side effects are less frequent.
And just to recap the pregnancy breastfeeding aspect in autoimmune disease.
It's complex, but the thinking has shifted. Stopping the drug can worsen the mother's disease, which is also risky. Lots of data now suggest hydroxychloroquine is relatively safe in pregnancy. No clear link to increased birth defects or fetal eye toxicity. Chloroquine is used less often. Both get into breast milk, but usually in low amounts considered unlikely to harm the infant. Still, it's always a careful discussion between the patient and doctor.
Okay, let's shift to current malaria treatment guidelines. CDC, WHO. What's key for diagnosis now?
Accurate diagnosis is step 1. Lab confirmation is crucial. Blood smear microscopy is still the gold standard. You can see the parasites, identify the species, estimate how many there are.
What about the rapid tests?
RDTs like Binax now are faster, great for remote areas, but they're less sensitive, especially if parasite levels are low. A negative RDT might still need a microscopy check if you strongly suspect malaria. And microscopy is still needed for species ID and counting parasites.
Any other tests?
PCR is the most sensitive and specific. Great for confirming species, finding mixed infections, or checking for drug resistance genes. CDC offers resistance testing. Serology antibody tests aren't useful for diagnosing an active infection.
So for uncomplicated Falciparum malaria from a chloroquine-resistant area, what's the go-to treatment now?
The preferred options are artemisinin-based combination therapies, or ACTs. Top choices are artemether-lumefantrine, brand name Cordam, if available, or atovaquone progonil malarone. Both are fixed-dose combos, good for kids over 5 kilograms too.
What if those aren't available?
Then quinine sulfate plus an antibiotic like doxycycline or tetracycline is another preferred option, or quinine plus clindamycin. Usually 3 days, but 7 days if the infection came from Southeast Asia due to resistance worries.
And mefloquine?
Mefloquine is further down the list now for treatment, reserved for when other options can't be used because of the neuropsychiatric risk and resistance in places like Southeast Asia. The general advice is, if a patient's already on a regimen and tolerating it, you don't necessarily need to switch just because a preferred one becomes available.
What about Vivax and oval malaria? The ones that can relapse.
Right, they have those dormant liver stages, the hypnozoites, so you need 2 types of treatment. One for the blood stage causing symptoms now, and one for the liver stage to prevent relapse later.
What drugs target the liver stage?
Primaquine phosphate or tafenoquine. But before using either, you absolutely must test for G6PD deficiency. Both drugs can cause severe anemia if someone has that deficiency.
Okay. How are they given?
Primaquine is usually taken daily for 14 days. Tafenoquine is a newer option for people 16 and older, taken only after the blood stage is cleared with chloroquine.
How about treating kids? Any major differences?
For kids 5 kilograms and up, the options are mostly the same as adults. Just careful weight-based dosing. Don't exceed adult doses. Doxycycline, tetracycline usually avoided under age 8. For tiny infants under 5 kilogram, options are limited. Maybe mefloquine or quinine plus clindamycin, or carefully considering Malarone or Coartem. And same rules apply for G6PD testing before primaquine and tafenoquine only for 16 plus after chloroquine.
So, we've really covered a lot of ground here. You've taken this deep dive into chloroquine and mefloquine. We've seen chloroquine's incredible rise and then its fall due to resistance. A huge lesson there.
Definitely a cautionary tale.
And mefloquine, still useful against resistance, but with those significant tolerability issues, especially the neuropsychiatric side.
A difficult trade-off sometimes.
And then the whole other story of hydroxychloroquine and autoimmune disease. It's just fascinating how these drugs have had such complex journeys.
It really is. Understanding how they work, why resistance happens, their toxicities, it's all crucial, both for treating patients now and for developing better drugs in the future. The story of these two drugs really drives home that need for constant innovation and vigilance against evolving diseases.
Absolutely. So, thinking ahead, given the resistance problems, the side effects, what do you think are the most promising avenues for the next generation of antimalarials? And what lessons from chloroquine and mefloquine absolutely must we carry forward?
That's the million-dollar question, isn't it? Future drugs likely need totally new ways of attacking the parasite, things it hasn't seen before. Combination therapies will surely remain key to slowing resistance. Understanding the parasite's basic biology better will reveal new targets.
And the lessons learned?
Oh, so many. Responsible drug use is paramount stewardship. We need rock-solid surveillance to catch resistance early. We need sustained funding for R&D. And we have to build safety into drug design from the start, learning from the challenges with retinopathy and neuropsychiatric effects. We can't afford to repeat those same mistakes.
It really makes you think. What other big, widely used drugs out there today might face similar challenges down the road? Maybe resistance, maybe unexpected long-term effects we don't know about yet? What can we do now to be proactive?
It's a vital thought. Antibiotics are the obvious parallel with resistance. But even drugs for chronic diseases could face issues as we use them for longer periods in more people. Proactive steps, better surveillance, deeper understanding of long-term effects before widespread use, developing alternative strategies early, promoting responsible use from day one. It requires foresight and investment.
Well, this has been incredibly insightful. We'd genuinely love to hear what stood out to you in this deep dive. What surprised you most about chloroquine and mefloquine's story? Or maybe you have lingering questions about how they're used today. Jump into the comments section and share your thoughts. Your insights really help shape these conversations, and we're always keen to explore these topics more based on what you want to know.